The TB program is very exciting. Always something new to learn, and I think getting your community involved in learning about TB and participating in your annual screening, you can get people really excited about it, and it becomes a norm. For the nurse to have a successful TB program, they have to invest in the education of the community.
One of the challenges that you have, that I have now, and I've had in previous First Nations communities in implementing the TB program, is the stigma that's attached to TB that's still present.
Similar to their days in the residential schools, where they were taken away from their communities and put in residential schools away from their families. With TB, there were sanatoriums, and people again could have spent from 3 to 5 years in a sanatorium.
You can imagine if they think if they have a positive skin test, that means they're going to be sent away from their family. Who would want to test? and so the education before doing a skin test is really important, so they understand that having a positive skin test does not mean you have active disease necessarily.
In Canada, the highest number of TB cases come from immigrant populations from countries where TB is endemic, but the highest rates are in Aboriginal people. So Health Canada, First Nations Inuit Health, have been working for a long time towards trying to decrease the rates in Aboriginal populations through a number of initiatives. Health Canada provides funding for tuberculosis prevention control services for on-reserve First Nations populations in British Columbia. And the way we do this is through a memorandum of agreement and contract with the TB prevention control services at the BC Centre for Disease Control.
So I think this is an incredibly unique partnership because the community health nurses have a voice, have a forum. We hopefully incorporate that with the communications with the nurse consultants at BCCDC. And then at a federal level, we have a connection with FNI, who funds the TBSA services for Aboriginal communities.
I'm the medical director for TB services for Aboriginal communities. One of the strengths of our program is that we have a lot of TB experts here at TB Control. We recognize the effort and the work it takes to run a successful TB program. And by recognizing that, we try very hard to ensure that we support local TB programming.
So our TB team, we collaborate well to provide a service to the band nurses. And that collaboration essentially is that TB is part of the CD communicable disease program, and it's a mandated program. Basically, because of that, the nurses have to carry out certain functions and they have certain responsibilities when it comes to TB, and we're there as a support system in carrying out that function.
That support can be a quick phone call, preventative screening of children, but that support can also be more formal TB educational sessions, local nursing in services, training of DOT workers, training of community health representatives, and also TB 101 training for nurses in the field. And if people do develop TB disease, then we work with the communities and the local healthcare providers to treat the disease and to treat it to cure, to make sure that those people never have a problem with TB ever again.
To me, the BCCDC site is on the end of a telephone. I've never actually been there. But the wonderful thing is when you call BCCDC, someone answers the phone, and if the person who you think you're going to talk to isn't there, they put you on to someone else. I've never been left hanging. Even if no one from the Aboriginal team is there, the people from the other TB program will also help you out.
Hi, welcome to BCCDC and the world of TB control. What I'm going to do is going to take you through to when a patient comes in or when a sample comes into TB control and what we do with it. So this is the hub of the Vancouver TB clinic. Patients come in to get their skin tests, x-rays, referrals by physicians, and basically diagnosis for tuberculosis. First step, usually what we do is we go through processing. People get a 939, which obviously you guys are aware of in the field. kind of getting patient information and so forth. This is kind of our big form that we've talked about, the 939. You guys, well, we've got a skin testing room, so people come in for skin testing. We enter it into the IFIS system, and then they'll come in to see a nurse. The physician will read their chest x-ray and make a diagnosis. We have all the supplies here to make sure that if somebody can't produce a sputum and we're suspecting TB, that we can get a sample, send it upstairs to the lab, go out for AFB and culture, and then hopefully get a diagnosis of TB and if they're infectious. As we know with TB, it's an airborne disease, so the building itself at TB Control has ultraviolet light and has 6 times air exchange so that the TB germ dies. Hi. There you go. And this is where the x-rays are taken. And when your x-rays come in from the field, we have Maria, our lovely x-ray clerk, and so she will process all the materials from the field. If somebody comes in for an x-ray, we get the report, and then she'll line up the 939 with the report and get the physician to do a report here so we can process that. The x-ray goes onto the grid, it's popped up here, and our physicians take a look at it. Hi Nick, how's it going?
Good.
Good.
Right.
We love labs. We love biohazard. Yeah, just go ahead on your own.
We'll spill a few things.
Excellent, thank you.
Have a few people running back and forth.
Fantastic.
Hi, this is Mabel. I'm the section head for the microbacteriology lab. We receive all the samples here in this lab. Okay, so I've prepared myself ready to work with the samples, and of the samples that I received, I have 3 of them right now. They've come with the right containers, and this one in particular is definitely a good sample, as you can see. All right, and I have another one, and I'm looking at it, and this sample, in our lab, this would consider insufficient, and we would not be able to process it very well. And this one, hardly anything in there. We would not call it, we couldn't do very much with it. It actually looks like an empty container in the sample. So once we receive it, we'll work in a cabinet like this, and once we process the samples, we then end up making a smear, a culture, and 2 cultures, smear and a culture. So after I have processed the samples, I have 2 types of media. This one is called the LJ media, or Lowenstein-Jensen's, solid, and this one is called the liquid media. So the samples that go in here after processing, and this one is incubated for 6 weeks, and this one is incubated for 8 weeks. Once processed, we put them on a slide for a smear, and we read the smear after we've stained it, and if it's positive, then the sample will be tested for a probe, AMTD, and if it's positive, we report it back as AMTD. But we still have to wait for the cultures to come up before we can report it. If the cultures come up, we send out a report. If the cultures don't come up, after 6 weeks, the report comes up negative, or after 8 weeks.
So this is where all the meds are processed and sent to you out in the field, either couriered or mailed to you. This is a really big piece of the coordination work that we do with the nurses in the field and the pharmacy. So once we've got a diagnosed positive case of tuberculosis, the physician writes the prescription, and these guys actually get the medications out to you ASAP. They're a very integral part of the work that we do at TB Control, because obviously without the medications that get to you on time, blister packed or in bottles, we can't really get treatment started. And so the other part of being at BCCDC at TB Control, we have clinical research coordinators, and one of the things that we're doing here at BCCDC is doing a rifampin study. All right, and thank you very much for visiting BCCDC and TB Control. Anytime you need us, we're just a phone call away.
It's a success story. Through good public health programs, through diligent follow-up and treatment of patients, we've been able to reduce tuberculosis to low levels.
We feel it's very important that the local TB workers do not feel that they're working in a vacuum and that they're working by themselves to control TB in their local communities. It's something that we do together.
All of the things that nurses can do in terms of, you know, the hands-on things for delivering the TB program and the screening, like actually the actual planting of the skin tests and, you know, sending people for chest x-rays, collecting sputums if they need to. Those are all skills that they can learn, right? But I think, and the most important thing that a nurse can do to have a successful program is to understand how TB has impacted her community.